Good morning, everybody. Happy Tuesday morning, wherever you are today, virtually. I'm standing in front of a packed audience here at Cohen Conference Center. Actually, not really. There's like 3 of us here. And I promise we are social distancing here in Cohen. And hope you are too. Hope you're well where you're at this morning. Thank you for joining us for PCH Grand Rounds. We're going to hope to do a virtual Grand Rounds, maybe not weekly, for the foreseeable future, but we're going to hope to have some here and there, and we'll certainly give announcements when we have a virtual Grand Rounds. It's my pleasure to introduce our speaker this morning. Our speaker is Dr. Derek Neilson. Dr. Neilson is the Division Chief of the Genetics Division here at PCH. He came to Phoenix Children's in 2018. He completed his pediatric residency and his fellowship in genetics at Rainbow Children's Hospital in Cleveland. He'll be speaking this morning on hypermobility disorders. A couple things to explain before we get to his talk. Number one is that, as we've mentioned before, we have a new CME attendance tracker system through U of A. This went live in March, but we just simply have not had a lot of grand rounds since March to be able to explain this well. We've sent some communication by email. This is applicable really to any doctors, both at PCH or anybody listening to this live right now, whether you're in the community here in Phoenix or elsewhere. You can use this. And basically, all you do is you text this attendance code 260-078 to the phone number listed here, 866-327-3062. And I'd encourage you to put that number in your contacts in your phone, the 866 number, and you'll get a quick text back from them saying that you registered. And the only other thing you have to do is if you haven't done it yet, you need to do a one-time registration on the U of A website. And if you don't know how to do that, let us know. Myself or our CME department office will send you the instructions. But once you do that, every time that you text in the code, it will be linked to you, and they will be able to track that credit. In getting your CME reports, printing them is going to be much, much easier on this system. Basically, you can do it instantly through the U of A website. If you have not registered yet, you can still text the code today, and then once you do register, it will know that you have texted them in the past. And this code is good to text for the next 24 hours. If you forget to do it for the next 24 hours, you can go to the website, the U of A CME website, and register after the fact. But for the next 24 hours, all you have to do is text this code. Last thing I'll mention is that we have a chat and Q&A feature. Dr. Neilson will not be taking questions live during the talk, but when he's done, we will have a quick moderated session. So if you have questions at all, I very much encourage you to use that chat feature, and then we'll let Dr. Neilson know the questions at the end. So without further ado, Dr. Neilson.
Thank you, and I'd like to thank Michael Olson and the organizers of this conference for giving me the opportunity to talk about this subject. It is, of course, a very frustrating time right now with the pandemic, and what we have is a room with 20 chairs that are spaced 12 feet apart and 6 feet front to back. So it's a very unusual setup today, and so I'm going to be talking about a frustrating condition during a very frustrating time. So I'm going to be talking today about hypermobility-based disorders, and I use that term very loosely because the definitions for this condition keep changing, and so what we have found is that people who are hypermobile for whatever cause can have a similar set of problems. So what we'll be talking about today is the natural history of hypermobility-based disorders, and come up with ideas for treatment and prevention strategies to improve and retain functional activity for these patients. So I usually think about these images when I'm thinking about hypermobility. The easiest entry point to see a patient having one of these conditions is actually in the hands, and actually being able to see if you can touch the thumb to the forearm. And so I have done this many times over the years, and I was actually just running the numbers to say, okay, if I've been doing this since roughly 2010, seeing about 15 patients per week, That puts me at about 6,000 to 7,000 patient visits by now. So that has given me a unique opportunity to get a sense of what kind of patterns we're seeing with our patients. And what's an interesting observation from the patients is that they always seem to come in saying, I'm a unique patient, I have something that nobody understands, nobody gets me. And when I see them, by now, it begins to become a situation where you really look like everybody else that I see. And so this has really changed the level of mystery for me, because this is no longer a situation where you say every patient is a unique kind of situation, but rather there are very consistent patterns among our patients. So what we're seeing, our entry point is really looking at hypermobility, and that is assessed by the Byton Score. Byton Score is a score of 9 different joints. Now, some of them we're scoring bilaterally, so it's actually 4 joints done on each side, and then 1 extra. So what we're looking at is hyperextension of the elbows past 10 degrees, hyperextension of the 5th digit past the 90-degree mark, apposition of the thumb to the forearm, and hyperextension of the legs at the level of the knee past 10 degrees also. So let's see, I think my laser pointer is not up here, so and hyperextension of the knee. So when we're looking at this knee extension, this is, whenever we're doing these examinations, it can be a little tricky because there can be some inter-rater variability. Technically, the way you're supposed to do this is to have a patient stand and lock their legs as far back behind them as possible. That was the original definition. But what I found is that you have to do a couple things. One is that you have to get down on your hands and knees to look at this properly, and that's not a good exam position for the examiner. And it actually helps to get a sense of the feel and how loose this leg is. So I actually like to have patients sitting and to pull their leg upward. So each of the prior examination maneuvers is done bilaterally, so that gives you 8 points. And then the last point is the ability to put the hands flat on the floor, so palms down, with keeping the legs straight, not bent. And out of those 9 joints, if there are 6 or more joints for a patient who is prepubertal, or 5 or more if they are going through puberty and above, that is considered generalized hypermobility of the joints. Now, when we were looking at generalized hypermobility of the joints, we think about the conditions of Ehlers-Danlos. Ehlers-Danlos Syndrome is a group of different conditions that all have something to do with abnormalities of collagen and connective tissue. When we're talking about the classic type, that is now defined as abnormalities of collagen 5A1 and 5A2, and it is defined as having the loose joints, papery skin, thin scars, and stretchy and fragile skin. It has a prevalence around 1 in 5,000 to 1 in 20,000. When we're talking about the vascular type, this is the one that everyone seems to talk about. And so when you look up Ehlers-Danlos Syndrome on PubMed or on the internet, this one has a very large number of papers associated with it. Yet it is actually the least common one that we see. It is caused very specifically by abnormalities in collagen 3A1, and the entry criteria or the diagnostic criteria for that are personal or family history of aortic, uterine, or bowel ruptures. So really big things are the definition of this disorder. It is much less common, 1 in 50,000 to 1 in 200,000. Hypermobile Ehlers-Danlos Syndrome is a condition that we know is familial. It seems to have a dominant inheritance pattern, but we do not have a gene for it. And this is despite the fact that people have been looking for this for a very long time. And so because of this, this may not be a single condition, but it actually may be a multifactorial kind of disorder where there may be the confluence of multiple genes or even environmental factors that play a role. It is defined as having loose joints with mild skin findings, and it is more marked by pain and disability than the others. Now, the prevalence for this one is a moving target, and right now we're going with an idea of approximately 1 in 200. But we really don't know because it depends on how you define this condition. Now, these are not the only types of Ehlers-Danlos syndrome, and there are many more, but they're actually very rare compared to these three, or at least in terms of the weight of medical burden that they apply. So I'm not actually going to go into those today. Some of the findings that help us recognize the classic form are this extreme stretchiness of the skin and abnormalities of the scar. So here we have a picture of a man who's pulling his skin from his face, and these are one of these classic style photos that we always see. And this is probably what most people saw in their medical school classes. However, this is not really the defining characteristic or the most useful characteristic. What we often see more so are these very abnormal scars. And this was a scar, this is actually a knee, so the kneecap would be up here, and this was previously a linear scar or linear cut that has now pulled apart over time. And what we see with our patients with the classic type is not just this stretchy skin, but rather that skin is fragile. So what we frequently see are scars all over the forehead and all over the knees, because whenever these patients run into something, which is quite common when they're toddlers, their skin splits open and forms very poor scars. Vascular Ehlers-Danlos, as I mentioned, has the major criteria of arterial rupture, spontaneous colon perforation, or uterine rupture. Those are the most commonly recognized. But also, carotid cavernous sinus fistula formation in the absence of trauma is now one of the main diagnostic findings. It is diagnosed either with the presence of one of these major findings, or we suspect that, and if there's a family history of one of those four, with a causative variant in collagen 3A1. And the diagnosis depends on genetic testing. And a lot of patients are referred for the needing to get a skin biopsy, but actually skin biopsies are no longer the preferred method for making that diagnosis, and they are only done in very rare circumstances now. There are some other findings that can be identified physically. So there does seem to be a form of lipodystrophy that goes along with this. So we often see this lack of fat deposition, and this can be present in the cheeks, underneath the eyes, and we can also see that in the skin and the hands. And this is not present early on, so often the younger children look fairly normal, but this is an evolving kind of pattern as our patients get into the teenage years. And this patient is actually in her early 20s. And this is the hand of that particular patient, and you can see this hand has this very aged appearance, even though this person is only 20. And this is related to the lack of fat deposition in the skin, allowing the easy visibility of the veins and that sort of aged and wrinkled appearance. We can also see frequent bruising with no identifiable trauma or in unusual sites. And then we can also see a few other findings that go along with connective tissue disorders, such as pneumothorax, congenital hip dislocation, hypermobility of small joints. Tendon and muscle rupture is fairly uncommon in the other conditions, and so that may point us closer to that vascular EDS. When we're talking about the diagnosis of hypermobile EDS, it used to be that all you had to have was a Byton score of at least 5, and then minor skin findings that did not qualify you for the classic Ehlers-Danlos syndrome. But now there's a more complicated scoring system which requires an entry of at least a score of 6 for prepubertal, 5 for pubertal patients, and if you're over the 50, it allows you to have a score of 4 or more. And you have to have 2 out of 3 of the following categories fulfilled, and we have to have the absence of any confounding disorders. So for example, we know that there are other connective tissue disorders that can have joint hypermobility, and there are also conditions that can lead to reduced tone, which can also show loose joints as well, such as Down syndrome. And so we wouldn't want to call a person who has Down syndrome as having hypermobile EDS when it's really due to the low tone. So when we're talking about these other categories, we're talking about systemic findings, and this you have to have at least 5 of the following list, which include unusually soft or velvety skin, or mild skin hyperextensibility, unexplained striae, bilateral piezogenic papules, multiple abdominal hernias, atrophic scarring, pelvic floor, rectal or uterine prolapse, dental crowding and narrow palate, arachnodactyly, mitral valve prolapse, and aortic root dilatation. It is very difficult to find 5 of these findings in anyone under the age of 12. So for the most of our patients, it's actually very difficult to make a formal diagnosis of hypermobile EDS unless they are in the teenage years. Another category is family history, and for that you have to have an affected first-degree relative, and this is because we know it is a dominant kind of a pattern. But that family member has to have been independently evaluated and the diagnosis made on these other categories. You can't say family history for both counts. And then finally, the other category is some sort of joint dysfunction. So this could be chronic widespread pain for more than 3 months, or recurrent joint dislocation or instabilities without major trauma, or just daily musculoskeletal pain in 2 or more limbs for more than 3 months. So basically what they're trying to turn the syndrome into is something that indicates that there is a problem with having loose joints, because we would see plenty of kids before this criteria where they just had hypermobility and nothing really seemed to be going on with that patient otherwise. And did we really want to call that child hypermobile EDS at that point? Because we knew that some of these patients may actually just get better, and it would have been inappropriate to give them a chronic diagnosis. So this tries to lean toward a more clinically relevant criteria set, but for a lot of our patients, it just misses the mark, especially for our younger pediatric patients. When we're talking about some of these skin findings, what we can see is that there are some abnormal scars that can occur, and on the left, this is patients who have hypermobile EDS, and it compares to patients on the right who have the classic form of EDS. And what we can see is that there can be widened scars, but they tend to have a normal skin thickness and feel more like regular skin as compared to the scars of classic, where they tend to be papery thin, and you may actually feel a divot as you place your hand across that scar. So knowing that there were a number of patients who seemed like they might be at risk for having hypermobile EDS, but didn't actually meet the formal criteria, the question came up, well, what do we do about that patient? Do we just ignore them? And so the Hypermobility Syndrome Association, as well as the International EDS Consortium, put together this whole other system called hypermobility spectrum disorder. And when this came out, this is one of those things where it really bothered me, because anything that you call a spectrum bothers me, because you could put anything into it. And so with this scheme, anybody with joint criteria and problems of the significant severity get the diagnosis of hypermobile EDS, and anybody who's not quite there is hypermobility spectrum. But hypermobility spectrum disorder also could mean you've got one hypermobile joint and that's it. So it becomes, again, that sort of larger grab bag where you say, well, what does that really mean? And the idea here is when they came up with this, what they were trying to do with the new diagnostic criteria was take the older version of hypermobile EDS and merge it with something called hypermobile syndrome. And with that one, it was basically if you had 4 joints plus chronic pain, they called that hypermobile syndrome or hypermobility syndrome. And so they merged these two systems to make this newer version of hypermobile EDS criteria. But again, that left out all these other patients who were not having significant problems. So in this whole scheme, I don't think we've done ourselves any major problems. We haven't done ourselves any major favors. We haven't really helped isolate those patients where we think this child is going to have problems, and we haven't been able to better elucidate what's going to be the natural history for any particular kid that we see. So we really have to be a little bit more careful as we follow our patients and make sure that we're looking for the known complications. So what do we typically see? In general, what we see with the younger patients, and this is children under the age of 9, is that usually the presentation is fairly mild. What we might see in the babies is that they have constipation. They may have a difficulty learning to walk. Usually they look clumsy or klutzy through the childhood years, might have difficulty with their handwriting, and they may have issues like growing pains. But none of that looks very bad. It sort of looks like, well, that's sort of the stuff that happens. And we often see a 1-to-1 ratio of males to females at that point. When our patients hit the teenage years, that's when everything seems to turn. And in fact, with boys, what we often see is that they can actually go through a phase where things get slightly worse, and then they get a lot better. And so we see them over time actually having a decrease in their flexibility, to the point where some patients, some boys, you might not notice that they ever had it in the first place. With girls, however, we tend to see an acceleration of problems. And what we'll see is more chronic widespread pain. We'll also begin to see the onset of dizziness with standing, and when that comes out, we see a whole host of other problems come out with that, which I'll get to in the next couple slides. At that point, what we're seeing is in the clinic is more of a 5-to-1 ratio of girls versus boys. And this is not because girls are now acquiring it, but rather what we see is a dropout phenomenon of the boys. It's actually hard to find them when we're trying to recruit for studies. In adults, what we'll see is that flexibility tends to decline. And over time, and when we're looking at studies for hypermobility, it's very rare to see any study that has more than a 9 or 10-to-1 ratio of females to males included in that study. So finding effective men is very difficult. And this has been a pattern that we have pulled out of our clinics, but also this has been recognized by other groups, and they've categorized these phases as the hypermobile pain and stiffness phases. Now, how common is EDS? This is actually one of those moving target kind of questions. It used to be that we would say, oh, hypermobile EDS is rare. It's a 1 in 10,000 to 1 in 15,000. But anybody who is seeing these patients in the clinic will recognize those numbers just do not hold up. There are so many more patients coming in to see us who meet these criteria. More recent estimates have been as high as 0.5 to 2% of the population. And those may be overestimates. And the problem is, how do you define this condition is going to influence what your number is actually going to come out to be. What we know is that hypermobility can actually occur in selected populations on a prevalence of about 10 to 20%. But of course, that depends on whether you're judging this by 4 affected joints versus 5 affected joints. And they don't necessarily imply any change in function due to that hypermobility. So what we recognize is that for all those people that are hypermobile, not all of them actually have problems. And if we go on an estimate of approximately 10% of people with hypermobility have problems, then you're getting closer to that 0.5 to 2% mark. Whatever number you're using, it is far more common than what we used to perceive. And the whole statement that I commonly see written on the internet, which is, I have a very rare disorder, just turns out to be false. There is a rising incidence based on recognition. A lot of this is internet driven. And this gets me to my quick internet digression, which is beware the internet. And I tell this to patients quite frequently. Happy people don't blog. And a lot of the information that's out there is actually written by people who are having problems, and they do not represent the views of people that are having this hypermobility or hypermobile EDS who've actually gotten through the problems and gotten better. The medical corollary of this is doctors don't write papers about people who are doing well. So all the medical literature is biased toward problems. So when patients get onto the internet, all they find is problem after problem after problem. And we also see that websites often conflate the different types of hypermobile EDS and suggest that if you have hypermobile EDS, for example, you're at risk of having your arteries or uterus rupture, and that is not the case. And so what we often see is when patients go into the internet unguardedly, that they can fall down a very dark psychological hole, even with so-called good information. So with that, what are the things that we see with this? I call this the 8 common problems in hypermobile EDS. Most commonly, we think about chronic pain and joint dislocations. That's sort of obvious. Temporomandibular joint dysfunction, also kind of obvious, just another joint. But then we also see autonomic dysfunction. So we see this presyncope, a postural orthostatic tachycardia. And you begin to say, well, that's a little weird. Gastrointestinal dysfunction. Okay, maybe there's some motility issues. Chronic headaches, tension type, and migraines. Okay, tension type makes sense. Migraines, where are those coming from? Anxiety and panic disorder. Now it seems to be getting a little far afield. Sleeping difficulties and chronic fatigue. And then this bruising and bleeding. And you begin to say, wait a minute. Some of these make sense, and some of these don't make any sense whatsoever. Where should anxiety and panic come into this condition? And I also asterisked bruising and bleeding just to say this is a problem that happens quite frequently. It often looks a little bit like von Willebrand's, and nobody has quite figured this one out. And I'm not going to talk about it any further in this talk, so I'll just mention here that it seems that the connective tissue doesn't seem to activate the platelets very well. But despite the number of different studies, nobody's quite figured out any more than that. So when you take all these different problems, I've seen articles written like this, where they take all these issues and they say, hypermobile EDS causes all of these things. And when I look at this chart, I just think, how is this helpful? What we really want to see is, can we put these into some sort of organizational scheme where we can actually make hierarchical relationships between them? Because what we really want to do is figure out if abnormal connective tissue is at the root of this problem. We want to know, where can we intervene? So we want to cut this tree down at the roots, not at the level of the leaves. And right now, when we're talking about most of the strategies that are out there, I think about it as trying to kill the tree by cutting all the leaves off. We want to cut the roots, or at least the trunk. So trying to get to a more proximal model of where this is all coming from is really one of the goals of hypermobility. So how do we break this all down? The way that I see this condition is that you can break it down into a couple different categories. One is a musculoskeletal system. And what we know is that there's joint instability and pain, but interestingly, there's also a proprioceptive defect. Gastrointestinal system, there's poor motility, there's some effects of the autonomic system. There are even models about altered permeability and things like that. As far as it goes, the GI system is very complicated, and I'd have to say probably nobody really understands it at the level that it really needs to be. I'm not going to talk about it any further because we could actually spend an entire extra hour or even more than that talking about that system. Instead, I'll talk about the autonomic system, which really the entry criteria for this is dizziness with standing. And what we see is that the autonomic imbalance that occurs because of this worsens or creates the majority of the other problems that we see. So I'm going to start with the easy stuff first, joint instability. With joint instability, what we can see is that it can actually start at the level of the foot. And what we see is that there's usually a collapsible flat foot. Most people say, okay, it's flat foot, no big deal. And what this is a graph of a person who has a Byton score of 7 compared to a person with a Byton score of 0, so no hypermobility. And what we're seeing is that there's this flattening of the arch as they've put pressure on their foot. And everything that's black is sort of less pressure, everything that is white is higher pressure. And what this means is as you put weight on the foot, the arch flattens and everything rolls medially. What this means is that the knee will actually move medially as our patients take a step, and that puts tension on this side of the lower leg. And then they actually have to recover by putting tension through these muscles here, and as these muscles actually exert tension, they will actually deactivate the muscles on the inner side of the surface of the leg. And so what we'll see is an imbalance of the muscle activity as it tries to pull this leg back after it's collapsed inward. And this will create a strain pattern of pain of the medial surface and the external surface of the upper leg. And this is a pattern that most patients recognize, or most physicians recognize, as growing pains. But what we recognize is that it has nothing to do with growing. It has everything to do with the way the person is moving. And we do see that it actually gets worse when patients grow quickly because the whole mechanics change rapidly. But it's a musculoskeletal issue and not necessarily from growth in and of itself. So in children, what we'll see is a lot of musculoskeletal pain, which is mostly in the legs at night, following days of increased activity. So at a soccer game today, legs hurt like crazy at 10 o'clock at night. In teenagers and adults, this pattern actually becomes more widespread, involving the neck, trunk, hips, and legs. And the majority of this pain is not some sort of mysterious pain, but it's really just musculoskeletal. It's muscle, tendon, ligament, and the attachment sites of ligaments and tendons to the bones. Usually, arthritis is infrequent, and in the pediatric population, it is extremely rare. So when we go to the orthopedist and they get x-rays and things like that, usually you see nothing. So the issue here is that with the musculoskeletal system, it's not just about loose joints. It's also about proprioception. So patients with hypermobility demonstrate poor lower limb joint positional sense. They don't actually know exactly where the legs are. Increased threshold detection to movement. So if you push them a little bit, it'll take them longer to recognize that they've been pushed. They have differences in finger positional sense. So if you put their hand inside of a box and say, is your finger up or down, they can't tell you which way it went. And with that, it means that static postural control is impaired. So there's more sway of their body. It shifts back and forth as they're standing. And there's also more concentration required to stabilize the body. So they tend to shift back and forth while they're moving. So this proprioception is very common for patients with hypermobility, this proprioception defect. And where does that actually come from? If you think about it, proprioception is a sensory issue that comes from the muscles. And the idea is that there are sensory organs in the muscles that will stretch and contract, and they will help signal the brain as to what that muscle is doing. And this whole process of sensation of tension and stretch is something called mechanotransduction, changing mechanical signals into nerve impulses. So the idea is if the connective tissue is not proper, you may not generate the proper signals to signal the brain. And these proprioceptive defects lead to poor coordination and balance impairments. And so what we often find is that our patients are very clumsy and klutzy. They run into things like tables, chairs, and door jams. They have difficulty learning to walk or ride a bike, trip up and down stairs if they can't see the stairs at night, these kinds of things. So a lot of our patients will say, I'm clumsy. And now we can say, yes, but now you know why. It's really coming from this proprioceptive defect. And as I mentioned, why should there be a proprioceptive defect? It's because of these things like muscle spindles, where there are afferent nerves that wrap around these bodies and respond to the stretch and tension of these particular bodies and signal through the afferent nerve the brain to tell them what that muscle is doing. And so it has been identified in patients with proprioception that it is an afferent defect. The signal that is missing is from the muscle to the brain. So the idea here, our model that we're working with, is that stretch and recoil are properties of connective tissues that affect the mechanoreceptors and make them work improperly. So putting it all together, persons with hypermobility have difficulty maintaining a stable posture. And so when we have that, then a shifting weight will cause excess movement, and our patients will be correcting, and sometimes that'll be overcorrecting or undercorrecting, and that will create an additional stressor on the joints that are already unstable. So this is a combination that leads to increased pain and dysfunction, and it can also lead to clumsiness and unusual injuries. We sometimes hear about increased fracture rates for patients with hypermobile EDS. When I hear about these, I usually ask what kind of fractures are we talking about, and usually they're not the usual ones we're thinking about. Usually they are issues where a patient was looking the wrong way, stepped off a curb, rolled their ankle, went to the emergency room. There was no fracture identified, but they put them in a splint, did an x-ray 3 days later, and guess what? Maybe there was a fracture, and so it always has an unusual kind of story, and it is usually more of a soft tissue or external kind of process rather than a fracture directly through a bone. So these excess fractures are more related to the proprioceptive defects, I think, than any intrinsic bone fragility. But when we put this all together, then we recognize that focusing on a single joint or a single area of pain doesn't actually address the underlying problem, because we are not addressing the balance and poor coordination. So what we're working on through our strategies for physical therapy, which is really the core strategy for our patients, is we're working on alignment, and so we give shoe inserts to help prevent that rolling ankle. We work on core stabilization, which addresses the proprioception as well as stabilizes the body. We work on strengthening of the muscles around the joints. We cannot make the joints more stable through surgery. We can do that, but it's only temporary, because what we often see is the ligaments and tendons have a tendency to stretch out again. So it tends to be a limited period of time that we can get stability out of that. And so what we're working on is this stabilization and strengthening, and the whole goal is to get our patients more active, and especially transitioning to aerobic conditioning. I'll talk about that soon. It helps to have experienced providers for hypermobility, for physical therapy. Inexperienced providers tend not to know the correct goals, so they may push the patient too hard or not know when to push through a problem. They may adopt an overly aggressive timeline, because what we find is our patients usually require therapy over months rather than weeks. And they often would focus on the wrong goals. So what we might see is if the ankle is hurting, they're going to really work on the ankle. But that may ignore the fact that the reason the ankle hurts is that the body is actually moving too much. So really there's no magic, but there is a different strategy that is used for patients with physical therapy. And so what the PTs will say is that it's the same skill set, they just apply it in a different way. And so they often call it an inside-out approach. We start with the core, even if that's the thing that is not the most problematic for the patient at the time. That's not the thing that hurts, but that's what's going to lead us to the greatest chance of success. And this is a picture of a group therapy, physical therapy, and some results or some feedback from the patients. You will feel so strong, gained more strength, gained more hope. And what's interesting here is you can see that they're all working with these medicine balls, but this patient here who has the knee ACE wrap, the knee's giving her a problem, but that's not exactly what they're working on. So it really requires a more overall global approach. Speaking of overall global, I'm going to shift now to the autonomic system. The autonomic system is what I call the everything else problem. Many of our patients have autonomic dysfunction, and it's usually manifest as orthostatic intolerance. Basically, dizziness with standing, or the sense of blacking out or about to faint with standing up. There are other terms, such as Postural Orthostatic Tachycardia syndrome. That's a situation where the heart rate raises by 30 beats per minute or more with a minimal drop in blood pressure. Most patients will come in saying, I have POTS. Very few of our patients will actually meet the criteria for POTS. That's a source of great frustration for them, because they'll go to the cardiologist, and the cardiologist will say, you don't have POTS, and they'll say, but I read it up on the internet, I have all the symptoms, how can you not find it? And this is really just a matter of definition. So we sometimes have to talk our patients through that difference. We can also see orthostatic hypertension, which is loss of blood pressure while standing, and neurocardiogenic syncope, which is a loss of blood pressure and a slow heart rate while standing up. So there's different varieties of how this may present, but ultimately it ends up causing the same kind of problem. Autonomic dysfunction is actually very common in hypermobility. In a study of adults, they compared 27 persons who were hypermobile to 21 controls. 78% had some kind of orthostatic intolerance, and that was compared to 10% in controls. And the whole idea here is that we have this whole feedback loop, and what is supposed to happen is when we stand up, we're supposed to have unloading of the baroreceptors, and they signal the brain that you're losing blood pressure, and the brain will send signals out to the arteries to cause them to squeeze, and it'll send messages out to the heart to cause it to beat faster. And this message out to these blood vessels does not seem to work properly, because all the blood keeps going down to the feet, when actually that constriction of the blood vessels is actually supposed to protect against that. So people with hypermobility seem to have more orthostatic intolerance, and conversely, persons who are diagnosed with POTS frequently have hypermobility. So what we see, studies showed that 91 persons with POTS 31% of them met criteria for hypermobile EDS, and 24% of them met criteria for generalized joint hypermobility. So they would have gone into that category of hypermobility spectrum disorder. So about half of the patients with POTS actually had some evidence of abnormal connective tissue function. So how does this even work? And the answer is we still don't exactly know, but the previous explanation was that there must be increased venous pooling. So there must be more capacity in the veins, so when you stand up, all the blood just kind of sits there. And there is a 500 cc shift in fluid volume from sitting to standing, so it sort of made sense. But there's more information about POTS that leads us to think maybe there's more going on. So patients with POTS in general have low fluid volume. They're hypovolemic. And they also have elevated angiotensin II, but an insufficient aldosterone response. So the idea here is it seems like the system is trying to respond, but it is not following through all the way. So although venous pooling plays into this process, that may not be the only thing, and there seems to be a lack of a compensatory response of the blood pressure while standing. A more recent study in 2014 looked at patients with hypermobile EDS, and this was done in Belgium, and this is sort of, that group is sort of like the mothership to connective tissue disorders. So when they do it, it's usually done fairly well. They found that 74% of their patients had autonomic dysfunction, and what they showed is that there was a decreased central responsiveness to sudden shifts in blood pressure. And also, there was increased peripheral sympathetic activation at rest. And this compared to one of the earlier studies, which showed that there was adrenergic hyperresponsiveness. So once again, there really seems to be more going on than just your veins hold too much blood. And so this really suggested an impairment of the feedback loop with some kind of consequent sensitivity of the efferent pathway. So where could this be coming from? And with that, we look again at that baroreceptor. So the baroreflex depends on connective tissue properties. The idea is, as blood pressure changes, it causes deformations to the arterial wall, and that will stimulate a mechanoreceptor. Okay, if we think back to proprioception, mechanoreceptors were sort of part of the problem. They didn't seem to be picking up these changes. And as these mechanoreceptors are being stimulated, this will change the blood pressure or the baroreceptor firing rate. So the idea is, if proprioception is impaired, could the baroreceptor be impaired in the same way? And just a closer view of this, a better model of how this baroreceptor works has come out in recent years. And what we know is that there are these piezo channels, piezo 1 and piezo 2, which change sodium and calcium currents in response to circumferential stretch and tension of the arterial wall. So these fibers actually wrap around this wall and sense the circumferential stretch. So the question is the baroreceptor dysfunctional? Well, it seems to act that way. So it actually looks like a mild version of baroreceptor failure. So if you're a person that has had radiation to the neck and chest, or if you're a person that was born without baroreceptors with familial dysautonomia, that actually presents as syncope, labile orthostatic hypo and hypertension, sweating, and emotional instability. And those are some of the things that some of our patients will actually have. Now, they are much milder. Basically, when patients with this lay down, they become hypertensive immediately. But the studies have been mixed about what the baroreceptor is actually doing. The 2014 Belgian study concluded that the baroreceptor actually seemed to behave the same in patients and controls. But it was comparing differences in activity, not necessarily absolute values. In a more recent study, Shaletti identified that there was higher baroreflex sensitivity at rest compared to controls, and also compared to tilt. So basically the baroreceptor sensitivity changes as you go from sitting to standing. And the sensitivity is heart rate variability in response to change in pressure. So it's measured as milliseconds in change of that QRS complex, and compared to the millimeters mercury pressure change. So thinking about this, if you think about patients as they get older and arteries become stiffer and less responsive, and we tend to get more hypertension, this is actually associated with decreased baroreceptor sensitivity. Meanwhile, patients who have chronically low blood pressure tend to have high baroreceptor sensitivity. So the whole system, so this relationship seems to be working as an inverse to how the blood pressure is behaving. So there's still a long way to go, but what this is suggesting is that this connective tissue property may be at the root of some of these abnormalities in the baroreceptor sensitivity. So the whole idea then is what we're seeing is that this baroreceptor seems to not work properly, and it's associated with an increased sympathetic response. Well, what happens with that increased sympathetic response? Well, just think. If you're faced with this, and this is what I tell my patients, it is normal to freak out and panic. Your heart rate goes up, your blood pressure goes up, you go dry in the mouth, you breathe faster, you feel sick to your stomach, you become wide awake, alert, and vigilant. And so what we see is that all these symptoms that come out under a circumstance of stress are actually at the root of the other problems that we see in our patients. So we see with our patients that have this increased fight or flight response, we see more anxiety and panic. We see episodes of racing heartbeat. We see suppression of the GI system, which can contribute and make worse the irritable bowel symptoms. We can see vigilance and alertness leading to a sleep dysfunction. So many of our patients have difficulty falling asleep because of racing thoughts, or when they are asleep, if something goes bang in the night, it wakes them up and they can't go back to sleep. And so with this sleep dysfunction, they develop a chronic fatigue. So most of the non-joint related symptoms seem to stem from this imbalance of the system towards sympathetic activity. And so this, to me, is really one of the roots of this particular tree. If we can take care of this autonomic system, then we can see a lot of improvement in the way patients are behaving. Now, how do we take care of this? Well, it kind of gets back to some of the functions of this baroreceptor. So first, we know that the baroreceptor controls blood pressure, and so it regulates blood vessel constriction. Okay. But the other things that it contributes to as well are the blood volume. And it doesn't do this alone. There are osmoreceptors and other kinds of receptors that play into this. But it does play a role in regulation of thirst and fluid retention. And so one of the things that we often see with our patients is that they are usually dehydrated. But when you say you need to drink more, they say, I'm not thirsty and I can't do it. Another interesting part about this is that this baroreceptor actually coordinates with centers of the brain to control pain sensitivity. And you say, well, why should it do that? Well, if you think about that example with the bear, if you were to be faced with that and your ankle is hurting, you don't want to be in a situation where you're saying, I really need to run away, but it hurts too much to do that. In that situation, you shut down all that pain sensitivity to allow you to run and escape. Then you find out later that, boy, my ankle really does hurt. So what we see is that this sympathetic activity can actually modulate pain sensitivity as well, and the processing of it by the brain. And so there are actually a number of different studies that show that if there is an increased sympathetic to parasympathetic ratio as measured by heartbeat variability, that actually correlates to increased pain sensitivity. Well, that's just very weird stuff. But what it tells us is that there's a lot more interconnectedness of these systems than we previously thought. So what do we do? In order to treat the dysautonomia, the first line is drink more. And as I said, our patients usually don't feel the need to do this, and we have to get them doing it as a matter of habit. Additionally, they have to drink more than everybody else. Our standard targets for our patients is about 90 to 120 ounces of fluid per day. And in addition, we add about 3 to 5 grams of additional salt. And many patients, when they hear this, kind of freak out, like, we can't have that, we can't have all that salt, because they kind of envision their heart exploding or something like that. But really, it's the cardiologist that came up with this recommendation in the first place, so it's okay. Now, so what we have to do is train our patients to drink in this fashion. One of the problems is that can cause increased urination, so sometimes we have to write notes for school to say they need more bathroom breaks too. Now, is this everything? No, it's not enough, because the way I view it is when you drink a lot, all that really happens is all this fluid collects down at the base of your feet. We're getting it higher, it helps, but what we really need is for that fluid to go from here up to here. Another way to look at it is if we're trying to get the level of this ball above this particular line, if we fill it up with more fluid, you get a bigger ball. In order to actually get this above this line, we need to squeeze it. We need to get that height higher with more pressure. So how do we do that? We used to try and do this with medications, but it didn't seem to work as effectively as we would like. And what we've turned to instead is aerobic exercise. And one of the studies for autonomic dysfunction, a study for patients with POTS, looked at exercise of 30 minutes per day, 5 days per week, getting their heart rate to 80% of its max rate. And what that study showed is after 3 months, patients had basically decreased dizziness with standing, increased circulating blood volume, their heart was more efficient, and measures corresponding to the functions of the baroreceptor had improved. So basically, after 3 months, there was an improvement in the physiology of the system. And they actually compared this to patients taking beta blockers. Patients taking beta blockers said they weren't as dizzy, but there were no other changes to the way the body was operating. Additionally, patients who were exercising reported increased quality of life. And where we think that increased quality of life is coming from is those other pieces, because we know that exercise has been shown to improve sleep, anxiety, irritable bowel syndrome, and pain. And if we're actually able to improve the function of the baroreceptors so that we are actually having decreased sympathetic activation, we may actually be able to affect all of these things by cutting them off at the source. So, aerobic exercise has really been the goal for our patients. And of course, when you tell patients that, this is usually the reaction you get. Seriously? So most of my patients, when you say this, they look crestfallen because they say, yeah, I tried that. Exercise was terrible. And the typical story that you get from your patients is, I can get on the treadmill for about 10 minutes, and then my heart is racing, I'm sweating, I feel this impending sense of doom, I feel sick to my stomach, and then I have to get off of the treadmill, and then I feel like I just have to collapse, and then I'm done for the next 2 days. The problem with that is they were standing. And that is the process or the pattern that we see when a patient is trying to exercise and then launches a sympathetic stress response while they're exercising because they're not perfusing their brain. So how the exercise is achieved is very important, and that's usually the missing piece. That study did not have patients on treadmills. It had them doing seated exercises, like recumbent bike or a rowing machine, or it had them in the pool. And the pool-based exercises were swimming or kickboarding, but we've also seen patients walking to the pool. And you can think about this in a couple different ways. This is actually very helpful for our patients because not only does it reduce the stress on the joints, but the water pressure actually provides additional peripheral vascular resistance, and that improves that blood pressure stability. So if you think about it, the class 3 compression stockings, the best you can buy, give you about 40 to 50 millimeters of mercury in pressure. But if you're standing in 4 feet of water, you actually get 50 to 90 millimeters of mercury on the legs. So chest deep water actually gives you a lot of boost to that peripheral resistance and actually sends all the blood to the brain. So we find that patients can actually go for an hour or more in the pool where they might have only gone 10 minutes on a treadmill. So chronic fatigue, pain, and fainting are the barriers. We have to change the way patients do their exercise and perceive their exercise. Now, there are medications. There's Florinef, and we use that to replace the low aldosterone. It does cause acne, so not every patient likes it. And I would just make a note that some people are using spironolactone for their acne, and that would actually go against the autonomic system. And some patients benefit from Metadrine, which is an alpha-adrenergic agent, so it's going to give us that squeeze. And then beta blockers are going to block that peripheral, that fight or flight response. But it also improves the preload of the heart, so it actually gets better blood delivery to the brain. So there are some medications, but those are really not the first line therapy for our patients, especially when we're talking about patients in the younger ages. With the teenagers, sometimes we have to use these, but the goal of these for every patient that I see is not to treat the disorder, the goal is to remove barriers to exercise, because that is where we see the long-term gain. So what can pediatricians do when they see this condition? So first of all, the biggest barrier that we face is recognizing the disorder, and recognizing it even if we're not talking about joints. So if we're talking about, here's a patient with anxiety and irritable bowel, or here's a patient with chronic migraines and irritable bowel or sleeping disorders, checking a little further and looking at the system as a whole to see if the hypermobility might be present. If it is present, then what we really want is physical therapy if there's evidence of pain and proprioceptive defects. And we may actually want to do this, especially in kids if they're not having it, if there's a family history of pain. So what we frequently see is the patient seems to be kind of mild and the parent has fibromyalgia. So that's a situation where I would consider it a higher risk for this child to proceed down that same pathway. We really want to encourage regular exercise throughout the entire year, and especially swimming. That is a sport that I like because it is actually something that you can do for the lifetime as long as you develop good technique early on. Fluid intake has to become a habit. The old idea that you drink when you're thirsty doesn't work for our patients. We have to push them a little bit more. And I think the other thing is that for pediatricians in the community, it's okay to push. The common mindset of patients coming in is help me, and sometimes it becomes a please don't make me do the hard things that are difficult for me anymore. And when we get into that pattern, it actually keeps going down that pathway where we're trying to restrict and restrict and restrict. And we really want to turn that around and help our patients learn that they can actually push through it and they can actually improve. There are many different referrals that we may make. The first ones that I would really suggest would be physical therapy and cognitive behavioral therapy to help develop coping skills. There are a number of different secondary referrals that we could make. I'm actually not going to go through this list just for the sake of time, but the idea is less is more. The more we can actually get our patients active and treating these issues on their own and developing those good habits, the better off. The more we send to specialist after specialist after specialist, the more it seems to reinforce that sick role and patients begin to retreat further and further into themselves. We have to reverse that process. And to summarize, Ehlers-Danlos hypermobility is a common condition, and it causes pain and multiple dysfunctions. The symptoms accelerate with puberty, and so that prepubertal state, recognizing it then, could be our window to prevent problems getting worse over time. The mechanisms underlying disability can be treated with physical therapy and therapies for autonomic dysfunction. And our core therapies are strengthening exercises, fluid intake, salt intake, and aerobic exercise. Now, when you say all this, you say, so healthy living? No, it's more than that. And so good communication is critical with our patients to help them understand that this is not just good living advice, but what we're actually trying to do is change the way their cardiovascular system is working in order to provide better blood flow to the brain. When they can get onto that kind of concept, we see a lot better improvement. Okay, so I went almost to the very end, but I will take questions at this point. Thank you.
Thank you so much, Dr. Neilson. We do have one question from the audience. And fantastic talk, Dr. Neilson. This is from Dr. Hartley. It says, as a hospitalist, frequently we see patients diagnosed with POTS that have central lines placed and receive IV fluids at home and come in to PCH with CVC sepsis, which we treat and then discharge them to go home and have the same pattern repeat. Have you had much success in changing this pattern?
No, I haven't had much success in changing that pattern. So I guess what I can say is, when somebody comes to me and says, I want a central line, or can you help us with that, my reaction to that is no. And precisely for the reasons that, for the problems of line infection, but more so is that it really seems to accelerate the process. If we think about this whole system as a feedback loop, what we're doing is we're taking away the feedback and we're basically replacing it by convincing the body now with our fluid infusions that everything is okay. And so now we have appropriate volume and the system has no need to change. And what I've seen with patients getting central lines is that they seem to need more and more and more frequent infusions. And it just seems to go down an accelerating pathway of therapy rather than actually get them to a point of being more self-sufficient. And so the goal for me and my patients is to actually help develop that self-efficacy and basically independence from the medical system. That process of the medical lines really promotes dependence on the medical system, and it goes the wrong direction. Are there patients that really need them? It's possible. I would actually prefer that anybody that needs a line would actually get, because the GI system is simply not working. There are some patients that have gastroparesis and those kind of things. I would actually prefer J-tubes because it actually replicates the system a little bit better and helps with the feedback loop rather than bypass it directly. I've seen better results with that. But there is no evidence-based, there's no evidence for success or failure of any of these systems right now, so everyone's just kind of doing what seems right, but I would say that it seems to go in the wrong direction more often than not.
Dr. Neilson, what do you recommend for primary care physicians when a patient comes to their clinic and the parent says, I was diagnosed with EDS, test my child, and when would you recommend a genetics referral?
Good question. I didn't really put that in. Sometimes the problem with these talks is when I say, you give the summary slide and you say, okay, so everyone knows what to do with this condition now, right? And they say, yes, we're going to send them to you. And then we're basically overloaded with patients that we don't have enough providers for. So if you think about that 1% number, if that's the true scale of persons with hypermobility having problems associated with it, and we're dealing with a city of 5 million people, well, we're talking about 50,000 people, a quarter of which are going to be children, so we're talking now about 12,500 patients that need to be seen. I can't see that many patients. So at least it's going to take a really long time doing nothing but that. So what we're really trying to work on is developing better understanding and better roadmaps for everybody to be involved in taking care of patients with hypermobility. We used to say, we used to have so many papers in genetics that would end up with the final statement is, in order to make a diagnosis of hypermobile EDS, you need to see a geneticist. And I just had to say, we just have to strike that out. It is not that difficult to make the diagnosis anymore. And I think the real question is there something else going on? And if we can feel reasonably assured that there are no other major family history events, like the ones described for vascular Ehlers-Danlos, and there are no other major skin or orthopedic findings, I think we can be confident in moving forward that at the very least for this child, we can do physical therapy. We can teach about fluid intake and exercise and how to do it in a way that works with the body rather than accelerates the problems. So I would still, what I would like to see in the future is that this is actually something that everyone is involved in taking care of. And then we may still provide some referral process, but more for those ones that don't quite fit the normal standard. In a sense, it's kind of like what you might think of as type 2 diabetes. If we said every person with type 2 diabetes needs to see an endocrinologist, we'd have a real problem for an endocrinologist. Instead, primary care doctors are now taking care of a large share of that, and it's the more difficult ones that are coming in.
We are, Dr. Neilson, that was great. We're out of time, so thank you so much, and we hope to see you guys again soon.
Thank you very much, everyone.